with
This meeting is being recorded.
we might need to mute everybody. Good evening, everybody. My name is Andrew. I'm with 5-Star Orthodontic Lab. Thank you all for coming this evening. We're very happy to have Dr. Brock Rondeau speaking tonight. We've been working with Dr. Rondeau and going to his courses for a little over 15 years now, and have taught a lot of doctors and helped a lot of doctors get orthodontics implemented into their practice. So very happy to have you here, Brock, and happy to have such a great working relationship with you, and excited for this evening and getting more people in the courses.
That's great, Andrew. We're really happy to be with you too. 5-Star Ortho is a fantastic lab, everybody. And if you're doing functional appliances, you really have to use that lab, because they know my technique, and we've worked together on designs of appliances. And the thing I liked about them too, they'll help you with your cases. Andrew is probably the #1 guy you talk to. And of course, Bobby Middle is very good too, the president. So they're a great lab. They help with cephalometric tracings. They help with design of appliances. They will tell you what cases to start and what cases stay away from, and do the easy cases. But I can tell you right now, you cannot do orthodontics without functional appliances. You cannot do orthodontics just by moving teeth around with Invisalign or braces. You absolutely have to have functionals first, and then you finish with the braces or aligners. But so I'm glad to be here, Andrew, and I'm really, really happy that everybody's here. And for the Dallas people, I'm really sorry the Stars lost last night, but
Had to bring that up, didn't you?
What about the next game? You never know. Don't lose faith in your team. My Toronto Maple Leafs lost too. Okay, here we go. So you set it up there, Lee. So Lee Larstone is here at Rondeau Seminars. She's the manager, and she knows everything about how to set the thing up. So if it doesn't work, please call Lee Larstone.
Don't blame me and don't blame Brock.
That's right. So tonight we're going to talk about Class 3s. And I know that a lot of dentists are afraid of Class 3s, but I'd like to show you 3 appliances that I think will work very well for Class 3 malocclusions. Okay, now there's Bobby, and that's Jeff.
Oh,
he's related.
Second.
Not working yet?
Just a moment.
Okay, so we're hoping this gets going someday.
It will.
Okay.
Just a moment.
We
There
just
we
keep
go.
seeing Andrew. That's good. You know, Andrew's good, but let's get somebody else on there, you know, like.
There we go.
There we go.
Okay, there we are. So let's go to the next one. Okay. So again, there's the Brain Trust. The 2 guys on the left, Bobby and Jeff, are the owners of the lab, and they're fantastic. I'll tell you another thing I like about the lab. They do exclusively ortho. They don't do anything else. So they're totally into ortho, nothing else on their mind they have to do. So just ortho, ortho, ortho. And they're probably the best lab in the United States. Okay. So the thing I want you to talk about first of all is when you're treating Class 3 malocclusions, look at the maxilla. If the maxilla is retrognathic, I want you to treat it. Okay. That little guy's got a retrognathic maxilla. His upper lip is behind his lower lip. There's another guy. His upper lip is behind his lower lip. So just go in there with the 3 appliances I'm going to show you and fix that, and fix it when they're young. Like that guy was 8 years old. What you don't want to do is treat that patient with a large prognathic mandible. So write this down. Prognathic mandibles refer to an orthodontist. Retrognathic maxillas, you're going to treat with one of the 3 appliances I'm going to show you tonight. Okay? So the 3 appliances I'm going to show you tonight are the anterior sagittal, which is removable, we use for younger patients. The fixed anterior sagittal we can use for patients when the teeth the roots have formed properly, and late mixed dentition or permanent dentition. And the tandem appliance, the same thing, probably late mixed dentition, early permanent dentition. Okay. So again, mixed dentition, anterior sagittal, it's mainly a dental problem. When the teeth are vertical, and you need just a little bit of movement to get them out of crossbite, use the removable anterior sagittal. And then I told you mixed or permanent dentition, use the fixed anterior sagittal. Again, it's a dental problem. And for severe skeletal problems, you're going to use the tandem appliance. And if you do that, these children are not going to have orthodontic surgery. And if you don't do it, there's a chance if the orthodontist they go to later on doesn't do functionals, they're going to end up with surgery. Okay. Also, traumatic occlusion, because when you get traumatic occlusion on the lower incisors, you get that recession. So that patient's got a crossbite, and you got to fix that. Obviously, you'd have to open the bite and move those front teeth forward. So look at this little girl. She's 4 years old. And she's an unhappy little girl. You can see she's not smiling. She's having difficulty chewing, difficulty eating, and she's got speech problems. And look at her. Look at the crossbite. Now you're saying she's 4 or 5 years old. You want me to treat that? I said, I do want you to treat that. And I'll show you what to do. And it's really easy. Okay. To open the bite, the easiest way is the permanent buildup of the primary molars. Okay. So remember, she's having trouble eating, speaking, and she's being treated by a speech pathologist. You know, she's 5 or 6 years old. The overbite is 4, and the overjet is -2. Okay, so the simplest things you can do is to put composite buildups on the lower primary molars. 4 buildups. I charge $150 a 2, so that's $600. You don't make a lot of money doing this, but boy, what a great result. Because the mandible rotates down and back, and now you don't have a crossbite anymore. Now you've got the teeth end to end. So instead of a -2 crossbite or -2 overjet, you got an end-to-end overjet. Okay, and that's the easiest thing you can do. And those kids will cooperate. You don't have to freeze them. You just add the composite to those teeth. And maybe have 2 millimeter space between the anteriors. Okay, so again, really easy, painless. Kids love it. They'll cooperate. And there she is. I mean, look at her bite. If you don't do something and you leave her, she's going to have orthodontic surgery, which is not a nice procedure. Now, what I do is I open the bite enough to allow the permanent incisors to erupt, right? How are the permanent incisors going to erupt if you got this deep overbite? So we keep adding to the buildups. If she grinds them down a little bit, we keep adding. You can see back there, the first molar has erupted properly to the new occlusal plane. We're establishing a new occlusal plane on a 6-year-old now. And we're waiting till the upper anteriors erupt. I normally don't do anything until the 4 anteriors erupt. But if I got traumatic occlusion, which is looking like what I got to move those forward. Okay. So I'm going to show you a removable anterior sagittal. Okay. This is a 3-screw anterior sagittal. You've got 2 side screws to move the whole sagittal part forward, and you got a midline screw to expand the arch and make more room for all the teeth. Okay, so here's kind of how it works. This is a different design where you have 1 screw just pushing everything forward, and that's one you can use also, and that pushes 4 anteriors forward. This patient had buildups, occlusal pads instead of buildups. They have no posterior molars, you'd have to use the occlusal pads, but I prefer the composite buildups. And they just turn that screw twice a week, and the front teeth go forward, and she's looking great. Okay, so we got the anterior sagittal in now. We've turned the side screws about 8 millimeters. We've turned the midline screw 3 millimeters, and you got a completely different arch now. Look at how that expanded that arch. Wow. These appliances are great. So I'm expanding the arch to make more room for the teeth. I'm moving the front teeth out of crossbite, and I've got enough room for all the teeth to erupt. And look at that arch. I mean, that's so much better than we had before. And look at her lip. She started with a thin maxillary lip. So we're moving the bone and the teeth. That's what you want to do. Okay. And when that sagittal's in, Andrew, maybe just tell us where you have the acrylic touching.
Yeah, so on an anterior sagittal, we'll build the anterior piece of acrylic a little bit different if you have division 2 incisors or like a good inclination to your upper incisors. Pardon me, if you have division 2 upper incisors, we'll build the acrylic up against the teeth so that you're moving the premaxilla forward, but it's also going to procline your incisors. Now, if you have a good inclination to your incisors, or if they're a little bit flared, then we'll take that acrylic and relieve it up off the teeth 3, 4, 5 millimeters away from the CEJ. And then if you had flared teeth, we could put a labial bow on it to help retract as you're doing your expansion. So there's a lot of different ways that we can design these appliances for different situations.
That's great. So you just call Andrew. What I want you to do is design the appliance yourself, and then call Andrew, see if he agrees with you. So now look at the teeth are erupted beautifully. Remember, we opened the vertical by doing the buildups, and the teeth have erupted beautifully. So look at those teeth. Look how nice she looks with just a simple anterior sagittal appliance with 3 screws and 4 buildups. Look, we've got an overjet now. We had a -2 overjet. Now we got a +2 overjet. I mean, that's so good. And if you look at the photo on the left, that's a class 3. The lower jaw is ahead of the upper jaw. But as soon as you open the vertical, the mandible rotates down and back, and you got a class 1. This is such an important thing to do for young children. Or you can do this on adults too. I mean, it's amazing. So we corrected the anterior crossbite. We increased the posterior vertical dimension. We eliminated the speech problems. Speech pathology is dismissed. No problem chewing now, no problem eating. And the muscles are closer to resting length. If you're overclosed vertically, your master and your temporalis muscles hurt. Okay, so now we just wait till all the permanent teeth erupt, and then we'll put braces on for a short period of time. But 90% of the work is done with those 4 buildups and the anterior sagittal. I mean, this is an easy way to do it. I mean, she did it. She turned the screws, and that's what helped the case. So look at the size of that arch compared to what we started out with. And then we put braces on for a year. We're not talking about braces here today, but then there's the final finish. And look at the little arch we started with, and look at the big arch now. Well, actually, we started with something smaller than that even. But anyway, there's a broad arch. Start with that, finish like that. So the fee is $2,500 for phase 1. And I know some orthodontists charging $3,500 for that. Okay, the anterior sagittal and the composite buildup is $2,500, and then the braces were $4,000, so $6,500 plus $500 for the braces. And these patients are in your practice. They're all over your practice. 75% of the children in your practice have a malocclusion, and I'd like you to treat those. If the orthodontist in your area or some general dentist area are not doing this, you need to do it. You need to help these patients. Okay, so again, that's a nice result. But the anterior sagittal was the best. She ends up with a nice full lip. Look at her on the left. She's got no upper lip, can't put on lipstick. She looks great on the right. And there's the mother, quite a difference in the daughter from there to there. Now, I believe that the staff should be trained. So I give my staff a test now and again. So there they are all writing their tests. And this one got 95. This one got 95. This one got 95. They're all showing off their tests. And of course, because they took part in the test and they did so well, they all get a bottle of wine. So I'm constantly training, and you need to do it too. And we're going to have a course coming up for staff soon online. My course, of course, is offered online. And also we've got a staff course being offered online coming up soon. You must have your team trained, and you must give them some tests once in a while. And we give you some sample tests to give them anytime you want. Okay, one other case. Here's another guy, simple anterior crossbite. He's 8 years old. He's got uneven gingival margins. Like, you need to fix that as soon as possible. You need to get the tooth out of crossbite. First of all, he doesn't look very good. Plus, he doesn't function well. Okay. So he had his tonsil and adenoids removed that stopped his apneic event. So this guy had sleep apnea because he had large tonsil and adenoids. And we teach that in the course, how you can diagnose those and write letters to the ear, nose, and throat specialist. So it also stopped his apnea and stopped his asthma by getting those out. So that was really nice. So if your tonsils are large, you're reducing the size of your pharyngeal airway. We talk all the time about opening an airway, and we certainly opened the airway in that first little girl by building up the teeth and opening the vertical dimension. And we opened up the airway by expanding the upper arch. So it's all about airway now. Okay, there's his photos to start with. And I would recommend that if you want to get Lee to send you this form, my TMJ health questionnaire form, highly recommend you give it to every single patient. to see if they have a predetermination for, if they predetermined to have a problem. You want to know it ahead of time. So he's got pain in the left ear, ring in his ears, and grinding his teeth at night. Perio's normal, treatment plan, and buildups again. Same thing. Open the bite with buildups. He wanted blue, so he got blue. They usually want white, but he wanted blue, he gets blue. So he likes the Montreal Canadiens. So unfortunately, they're not in the Stanley Cup playoffs this year. So you can see from that appliance now, Andrew, you can see on the right-hand side, that acrylic's touching the teeth. But on the other side, where you've got the crossbite, it's not touching. So maybe you'd recommend adjusting that a little bit when we put it in the mouth?
Yeah, absolutely. So this is one thing that's really good to talk to me and Bobby about while we're designing appliances, is because in a case like this, of course, you have one tooth that's not in crossbite and then several teeth that are. So if you just send a case in to the lab straight into production without doing a consultation with us first, the techs are taught not to assume anything that you're trying to do with the case. So they'll build the acrylic up against all of the teeth, and then it's up to you to make changes to it when you're using it on your patient. But if you were to talk about this case with either me or Bobby first, we would have it designed already like that, to where the acrylic was butted up against the teeth that needed to move and then taken away from the teeth that didn't need to move.
Right. So you need to use them. I learned a lot from them over the years, and some of the dentists use them in almost every case. They phone them and ask further advice. Now, when you're doing the anterior sagittals, first of all, you got to have good posterior anchorage. So you see, we've got double Adams class, 2 class on each side. Always try for 2 class on each side. If the farthest tooth is going to be lost soon, like the D, then put them on the E, the primary second molar, and the first permanent molar. And the thing I forgot to mention, you put the cuts always distal to the laterals. If you put the cuts distal to the laterals, the teeth will move forward. If you do it another way, you'll start distalizing the posterior teeth, and you don't want to do that. But if you tell Andrew what you want and send him the design, they will phone you back and help you with the design. So there, we just turned those screws. I adjusted the acrylic. You can see from the one on the left where I adjusted the acrylic, so it's not contacting the teeth that were already out of crossbite. You just want to move against the teeth in crossbite. And those screws open about 8 millimeters. And it's so easy. This was done, I think, in about 3 months, it was corrected. And so really simple. And these guys are 8 years old. He doesn't want to look like this. And I tell him, look, you don't want to look like this. You want to have nice straight teeth. So wear the appliance, turn the screws twice a week. That's all you have to do. Take it out, turn the screw, put it back in, and you'll end up okay. Now look how he ended up with even gingival margins. He looks great. And all he had was 4 buildups and an anterior sagittal. There's no reason in the world why that case should be left till the patient's 13 years old and gets all their permanent teeth in. That should be fixed now, and you should do it. You should do it. This is easy stuff. So we teach this in the session 1 of the course. The course is 4 sessions. And again, right at the crossbite, looking good. That tooth that was lingual, the central and the lateral, both lingual, now they're straight. And when we expand the maxilla, it's very important that you're going to open the airway and increase nasal breathing. Now, I talk all the time about that, and that's so important. So there he is, showing off his Montreal Canadiens hat and his new smile. He looks a lot happier, doesn't he? I mean, on the left, you can see smiling, but he's not that happy. On the right, he's just really happy. He really loves the smile. And then we just leave him like that until all the permanent teeth are out. Now, sometimes when you do phase 1, you don't have to do phase 2. The teeth come in almost perfectly and you don't need a phase 2. So that saves the mother a lot of money. So in this case, phase 1, remember the same as the last case, anterior sagittal, 4 buildups, 2,500. Remember, a lot of the time was him turning the screws. You don't have to see the patient every month, bring him every 2 months. And as soon as it's corrected, you don't have to bring him anymore. Once he's got the crossbite corrected, you can take the appliance out. So there he is, looks a lot better. And that was it took 4 months. 4 months to go from there to there. What a difference. He looks, look at the look on his face on the left. He doesn't look that happy. But look at this face, look at the face on the right. He's just so happy. I mean, that gives you a lot of satisfaction when you can take a little guy like that and give him a beautiful smile in 4 months and actually get well paid for it. So now I think we just waited till all the permanent teeth are up, and then I did braces on him for 12 months. 12 months in braces, he looks pretty good. Then we use a retainer. Andrew makes these now with a clear labial bow. And they're fantastic because the patient can't see the labial bow, not like the old Holly retainers, Andrew, right?
Yeah, well, actually, a little bad news is the manufacturer discontinued this style of bow, so we can't even get it anymore. So what we typically do now is we make a Holly retainer, but we put acrylic over the labial bow.
Oh, so you
because-
can't see it. Okay.
Yeah, so I mean, we do it sometimes with tooth shade acrylic. I don't think it really looks that great, to be honest. So typically we do clear acrylic because it is good to contact more surface area on the tooth for retention. But yeah, unfortunately, we can't make these really pretty ones anymore. The materials aren't available.
I think there's a material called clear bow. that
So
I've
we
heard about.
tried that.
Tried that? Okay.
This was years ago, 6 or 7 years ago, and we didn't have very good, they're not as good of quality as the QCMs.
Okay.
They tended to distort and warp a lot. So
Okay. Well, you guys know what you're doing, so just keep being innovative. Okay. So there's a nice clear bowl, but if he's doing something clear, that's what you want on there. And there's the final result. Looks good, but most of the work was done with that appliance. Okay, so the crossbite's corrected, crossbite corrected. Again, I charged about the same. I charged $2,500 for phase 1, took 6 months. Phase 2 was 12 months, 4,000 and 6,500 and 500 for the records. And look at the gingival margin, but they were fixed with just the anterior sagittal in the first 3 months. So just an easy case. So you want to do phase 1 because you want to develop the maxilla non-extraction. You want to correct the anterior crossbite as soon as possible. You don't want a functional class 3 becoming a skeletal class 3. A functional class 3 means the patient closes end to end and then goes forward into the anterior crossbite. A skeletal class 3 means they bite into an anterior crossbite right away and they can't bite end to end. You want to increase upper lip support, prevent resection of lower incisors, and prevent surgery. So I have written a book, Early Orthodontic Treatment for Children. It's got 19 cases from start to finish, including anterior sagittal appliances in there. And of course, the thing I really got that's the best is my mini residency, where patients come to offices and actually work on patients every 2 months, live patients, because you can look at photos and slides all your life, but there's no comparison. Working on live patients and talking to live patients really helps. So we do have that. We'd meet on a Thursday night for 5 hours and go over their cases in case they're going to present the next day. And then we have a nice dinner. And the next morning I lecture for 2 hours. And then after that, they go into the clinic and they work on patients under supervision, and they bring their staff and we train them and train the dentist. Okay, so that's kind of neat. We've been doing this for about 5 years. And there's a picture of the guy that I really like that took my course. He's got his assistant working hard, which is what's supposed to happen. And he's watching again. And now he's actually working. Okay, so I think he's got about 200 active cases going after 2 years. Really loves it, said it saved him from being bored with dentistry. So some of you, if you've been in dentistry a long while, may be getting bored yourself and you want some a new interest, something to stimulate you a little bit. Well, let me suggest orthodontics for you, because you'll never get bored with ortho. You'll never get bored with helping patients. So we have mini residencies in London, Toronto, and what would interest you is Houston and Chicago. And we actually started 2 new ones, one in Vancouver and one in Miami. But most of you are 5-star clients, or you're in the Houston, Chicago area. And so we got 2 great mini residencies there in those cities. So you call Lee and we can set you up with one of those if you want. So there's Lee. you got any problems, go Lee, L-E-E, at rondeauseminars.com. And she's a tremendous help to you, whatever problem you have. Okay, so now I'm going to show you for mixed or permanent dentition, for a patient who won't cooperate, or the mother wants a fixed appliance, use a fixed anterior sagittal. So here's a patient, 20 years old, with an anterior crossbite. Look at her crossbite. Quite the hairdo. Anyway, and you can see what's my criteria. Deficient maxilla. Look at her lip. Her lip is thin and it's back. It's behind the lower lip quite a bit. And she'll look a lot better when I move that upper lip and teeth forward at a crossbite. So there she is. Okay. So she's got a class 3 molar, class 3 cuspid, and a posterior crossbite, and an anterior crossbite. Okay. Tell me how you're going to fix that with braces. You put the brace on those teeth, you'll bite them off. You know, that's an orthopedic problem. Can you see the bone in the lower slightly ahead of the bone in the upper? You got to get that fixed. You got to use orthopedics. You got to use an appliance from 5-star to fix that. You can't fix that any other way, in my opinion. So you have to learn cephalometrics if you take the course, because cephalometrics are part of your diagnosis and treatment plan. But I love this line called the S line. I draw a line from the middle of the nose to the soft tissue chin, and you can see quite clearly what's going on there. The upper lip is 5 millimeters behind the line. The lower lip is 2 millimeters ahead of the line. So we have to fix that problem. We have to make those lips the same. So she was told, she went to an orthodontist, and the orthodontist recommended jaw surgery. Now, my guess at that was the orthodontist doesn't use functional appliances, because if you use functional appliances, you don't have to use jaw surgery to fix this case. Just use one of Andrew's appliances and no surgery. Okay, so she had a deviated septum and dizziness, and jaw is tired when she wakes up, and that she's clenching, and she's got a few problems we got to fix up. But it's amazing when we fix the bite, how many of those problems we fix. Now, she's had her tonsil and adenoids removed, which is good, and she's a mouth breather. We're going to try and solve that problem. She's having TMJ problems, headaches, neck aches, dizziness, and clenching. We're going to deal with that. And in my course, we talk about how you can fix that, how you diagnose it. Skeletally, she's got a retrognathic maxilla and a constricted upper arch. And dentally, class 3 molar, class 3 cuspid, overjet -2, overbite 4. Okay. So the treatment is almost the same as I showed you before. We're going to do the buildups to open up the bite. So he's got permanent teeth, so we build up the 5s and the 6, the second bicuspid and the first molar. And then she wants clear braces. And we'll get to that eventually, but here's the buildups. That's the first thing you have to do. And remember, the thing about class 3s, the class 3 you want to treat is a deep overbite. The class 3 you don't want to treat is a skeletal open bite. So remember that. Deep overbite, easy case, open bite, difficult case. So we put composite buildup. She wanted white on the second bicuspid, and I wanted to put blue on the first molar, because then I can take it down and I can see where the tooth is compared to blue. And we immediately opened the bite. She immediately went end to end. Remember, she was -2 overjet, right? -2 overjet. I opened the vertical and she immediately went end to end. So her mandible rotated down and back 2 millimeters. Now, all we have to do is torque those teeth forward. And ideally, with a sagittal, I prefer when the teeth are very vertical. Because if they're flared, now Andrew's got a trick for that. He puts a labial bow on there. But I much prefer when I use an anterior sagittal to have the teeth vertical or lingually inclined, because then I don't have to worry about flaring the teeth or using a labial bow. Okay, so there it is. There's the anterior sagittal. Okay, so it's kind of neat. It's got acrylic behind the upper 4 incisors. It's got a midline screw. It's got nickel titanium coil springs. Can you see the nickel titanium coil spring down there just opposite the molar and how compressed it is? I think that's a better picture over here on the right. And you can see We put flowable, now there's no flowable composite on that. There should have flowable composite on the first bicuspid. And the other thing you must do, you can see on the photo on the right, where I've added composite to hold it down against the lingual cemento-enamel junction of those teeth. If you put the acrylic against the incisal edge, you're going to flare the teeth. But this is a common thing that 5-star do. They put the acrylic down low against just the root or the bottom of the crown, lingual part of the crown. But then I find you have to put composite there, or when you turn when the thing activates, it'll come right out. So that's what I do, and it works great. Andrew, I know you make a lot of these. Anything else you can add to that?
Yeah, just want to stress it's very important if you're going to use something like this to bond that composite, because anything, especially that's spring loaded, it can come apart. It's part of a rod and tube mechanism. So when you activate that spring, if there's not composite there to hold it in place, it'll just completely come apart. So very important to do that. We also have versions of this with a gear that the patient turns rather than spring. Even with that, it's good to bond composite on the lingual of the teeth above the acrylic, because it has a tendency to slide up the incisal edge rather than to move the bone forward. So that's all I would say is very, very important that you add that composite on there.
So can you look at the photo on the left to show the compressed coil spring on the left side, and then look at on the right-hand side how it's bigger? Because the coil spring, you turn that little Gurin lock, and he'll give you a little like a screwdriver. What do you call it? To turn the Gurin lock and activate that coil spring. And you do it gradually. And if you do it gradually, you won't flare the teeth, you won't hurt the patient, and you'll help the bone go with the tooth, because you're moving bone and teeth. And you're not flaring the teeth. You'll see when I finish the case, the teeth are not flared. If you don't make it correctly, and you've got to go to a lab that's used to making these. I mean, again, 5 stars exclusively ortho. That's all they do. If you send to other labs, I mean, I'm not sure what's going to happen to you. But if you send to them, because we work together on design of appliances, then you're going to have a lot less problems, because he knows exactly what I want you to do. When I say it's a fixed anterior sagittal with a nickel titanium coil spring and a Gurin lock, he knows. And then he also said you can make it with screws, which the patient turns. So there's all kinds of different designs. And I would say, ask him what I recommend you design it, and then you ask him what he thinks of the design. Certainly use them for the first 15 or 20 cases, because it's free. It's a free service. So if you have to pay him an extra $5 over the guy next door, and you get his ability to design and give you, help with the case, it's certainly well worth it. I actually have told him many times I think their fees are too low, because when I compare what you're paying in the States compared to what I'm paying in Canada, I know there's a 30% difference in the dollar, but I'm telling you, every time I meet you, I said, you guys should raise your fees. And of course, everybody in the course says, no, we don't want that.
They say boo.
That's right. They boo me out of the room. But look at the difference now. So that's 4 months. Remember, we put that in. We got an end-to-end bite by opening the vertical. And now with that coil spring activating the 4 incisors forward, we're out of crossbite. I mean, it looks like a class 1 now, right? I mean, he started out class 3 with a lower jaw ahead of the upper jaw. And now you can see on the right, we've moved bone and teeth forward. Okay, both bone and teeth have moved forward. And we would expect to have a nice looking upper lip. Well, look how much that's open. And you control it by how much you turn that Gurin lock. So you're in total control. And when you expand it as much as you want, you can put flowable composite on that coil spring and deactivate the coil spring, or just stop turning it. And once you get there, I mean, you have to hold it maybe for 3 or 4 months, and then you can take it out. And then the bite will hold it there. If you got a cross bite, Now, I would prefer to have a little more of a deep overbite. So as you say, I can't do it because the lower incisors are hitting that composite right behind the teeth. But I'd like to keep going. And then eventually what I have to do is take that off and create a bit of a deep overbite to hold the mandible back. Now she's 20 years old, she's not going to grow anymore. So that's not a problem. And this is just an ideal appliance for teenagers or late mixed dentition. Early mixed dentition, when the centrals and laterals have just erupted and the roots are not completely formed, I would prefer to use the removable anterior sagittal. But once the roots have formed, you have a look at the x-rays, and then I would think seriously about using a fixed anterior sagittal. So Andrew, how many doctors are going fixed and how many are going removable?
You know, I'd say we probably make more fixed than removable, but not by much. I found that it's kind of a doctor to doctor preference thing. Some people love removables because they're great for hygiene and patients get excited about wearing them. And some people just don't even want to mess with compliance. So if I had to say, we probably make more fixed than removables, but it's certainly pretty close.
Well, it's going to work with fixed, right? What I do is I ask the mother, how cooperative is this patient? And if they're very cooperative, then I say, well, we can go removable. If they're not cooperative, I agree, you got to go fixed. I let the mother be in on the decision. Oh, there she is. Well, now we got a 2 millimeter overjet. 4 months, no surgery. 4 buildups and a fixed anterior sagittal. Do you think that mother is happy with me? She actually wrote an article about me because I helped her with her TMJ problem, saying that I saved her life, which is a pretty bold statement. But I fixed her daughter, and she's pretty happy with that too. And look at the change in the profile. Look at the lip. Look at the lip. She looks so much better. She looks older on the left. She looks younger on the right, and yet she's 5 or 6 months older on the right. Looks so much better, and that's so easy. I mean, we changed her whole life. She'd had surgery. They could have cut nerves. They could have done all kinds of things to her. I mean, this is just the way to go. And she certainly looks nice with that smile, showing a little bit of gum tissue, but she was in the beginning too. Anyway, and then I put braces on and finished her, but I just wanted to show you what the appliance did. The appliance did 90% of the work, but she did have braces for a very short period of time, maybe 9 months. So, I mean, this is so rewarding. I know I changed her life. I know I changed her smile. I know I prevented her having surgery. And all I needed was 4 buildups and a fixed anterior sagittal from 5-star to do it. That's it. So in the book, of course, we also have a chapter on the fixed anterior sagittal. Maybe a different case, but something's in there. Now, just a quick promotion. My level 1 course is on special tonight. It's 4 sessions. And can you see, look at the 4 manuals over there, 1, 2, 3, 4. Each one's about 250 pages. And it's full of colored pages of cases. I've colored pages. I've got those in the book and I've got them in the course. I think the current price, I can't see everything. It's 47 something. And the webinar special is $39.80. So it's special deal. So call Lee at 877-372-7625 or email her and she'll get back to you. But she's phenomenal. And of course, we have courses coming up in Chicago and Dallas. And there's the dates. If you go online, rondeauseminars.com, you can look at all the details of the courses and the dates and everything else. Would love to see you at one of those courses starting in September. September in Chicago and starting October in Dallas. Okay, last one. Zachary, skeletal problem. You're going to see. Look at his mid-face deficiency. Wow. His nose and his chin are quite close together. He looks like a denture patient who's overclosed vertically, who's not wearing his dentures. And look at that face. He's 10 years old. Look at him. Look at that mandible. Look at his upper lip. He's got no upper lip. He's got no upper lip. He's got short lower face height. Okay. There he is, biting in the roof of his mouth. Or he's not biting the roof of his mouth. Sorry, he's got a deep overbite. Got a deep overbite of 4 millimeters. But what did I tell you about deep overbites? Deep overbite, class 3, open vertical, you're golden. So I love it. This case is not tough for me, and not with this appliance. How could you treat that case with braces? The other thing is, he's 10 years old. He's going to grow to 17. His mandible is going to grow more than his maxilla the next 7 years. So you better get in there and fix that fast. So we did. Class 3 cuspid, class 3 molar. I mean, look at the bone. Look at the upper, the maxilla compared to the mandible. I mean, that's really a big class 3. And so he's had a fairly narrow upper arch, not too bad. There's the lower arch. He's been to one orthodontist who's been monitoring him for 3 years. So what is he doing monitoring this for 3 years? What does he say to the mother for 3 years? Oh, this is bad. Oh, this is bad. Oh, let's wait till the teeth come in. We'll decide. Well, no, mothers don't want to wait, and mothers are smart. They know something should be done now. You can't wait. Can you think of another medical dental procedure in the world where the best time to do it is 13? That's ridiculous. It's got to be done right away. It bothers me that all orthodontic practitioners, general dentists and orthodontists, are not trained in using functional appliances in either ortho school or dental school. I think it's a shame, because in South America and Europe, they're using these appliances, and they're not using them as much in North America as I'd like to see done. Anyway, that's my own personal opinion. Okay, you got to have a Panorex, you got to have a Ceph, you got to have a summary, you got to have a chart. Our chart's 12 pages long. So you're going to find out a lot about that patient and make the right diagnosis. You got to have a perio exam, got to have a TMJ exam, and the diagnosis, there's no functional problems, thank heavens. But he's got a retrognathic maxilla, and his mandible's a little prognathic, but once we open the vertical, his mandible rotate down and back to normal. Okay, so one orthodontist recommended headgear and 2 suggested surgery. Now the headgear was a good idea, because a forward pull headgear moves the whole maxilla forward. And before I found the tandem, we were using it. I don't know, Andrew, you were around long enough to see them use face masks? Maybe not, eh?
Yeah, no, we still have people that use the face mask.
Yeah, and there's nothing wrong with it. It's just that they like the tandem so much better. So, okay, what are we going to do? Again, the upper arch needs some expansion, so we put a Hyrex screw in there. So you turn that screw twice a week until you get the expansion you want. And now the lower, you've got to put something to open the bite. But the opening was so big between the teeth at the back, I couldn't use buildups. So I had to use a special little appliance with acrylic. And if you look, I've got an Adams clasp on the molars. I've got C-class on the bicuspids and put composite there so they won't come off. And the other thing I've got is a buccal tube, which Andrew puts into that lower splint almost, and a face bow is going to fit in there at night. So there's the face bow. So it just goes in at night, and we hook up class 3 elastics and pull the whole maxilla forward. Okay, so there it is. There's the 2 parts. So the lower has 2 parts, the face bow and the lower splint to open the vertical. And you can see I wanted the vertical opened so I could get rid of the crossbite in the front. And because it was back 4 millimeters, I could not put composite on there. It would have thrown off the root crown ratio. So I had to use acrylic over those lower posterior teeth. Again, if you sent something to Andrew and he would tell you what to do, he would know that you have to open that vertical with acrylic on the lower. So C-class for retention, again, almost end-to-end. 5 millimeter acrylic pads, open the vertical, mandible rotates down and back, corrects the class 3 almost immediately. It's just absolutely amazing. It's so easy to do. So don't be afraid of class 3s when you got a deep overbite. Remember, only if you got an open bite. Okay, So there we are. It's coming forward beautifully. And that's what happens with the tandem. Now it looks like quite a contraption. Okay. I mean, the first time I saw that, because it was taught to me by Leon Klempner, who's an orthodontist friend of mine now. He showed me this about 20 years ago. So you put the face bow in the buccal tubes and you hook an elastic up from the upper hyrex to the hook on the lower face bow. And you do that, they wear it all night. And after the first month, they double up on the elastics. Okay, and Andrew sends the elastics.
Mhm.
He'll send you all the pieces and the elastics, right?
Yes.
How many pounds are you selling now? Are you sending? How many pounds is that elastic? Any idea?
Oh, like the size and weight of it?
Yeah, how many
Yeah.
ounces? Yeah.
Quarter inch, 6.5 ounce.
Okay, that's what I'm using here too. That's good. So, and put 2 in after the first month. Okay. But it works like a charm. If that hook was back a little farther, usually, Andrew, we put that hook on the upper distal to the cuspid, right?
Yeah. So now when we make it, we leave it a little bit more distal than where it
Yeah.
is now in that. And then we also put the hooks on the tandem bow more on the front of the bow instead of on top like that
Right.
one. So you get a longer pull on the elastic. That's right.
So should I criticize that Canadian lab that made this for me and say, look, I'm going to tell them what you said? No, the point is, you know, I think we're doing that now too, because this was one of the first cases I did. And it's also removable. And now most of the cases are fixed. We talked about that, I think, previously. And so anyway, you can see whether when you put that elastic on, so this is daytime. So during the day, you want to put the Class III elastic on also. So you go from a hook on the splint on the bottom to a molar at the top. But you can imagine when that patient opens wide that lower will try to pop out. So today we would prefer to do fixed, but because I had to do the buildups, I went removable to start with. But you can see you better put good retention. We got 3 clasps on both sides or that's going to come out. And that's what it looks like with a normal vertical dimension. I mean, already it looks better, right? I mean, look at his lips going up like a moon on the left, and look how his lips will look much better on the right. Same hairdo though, right? Same guy, just only maybe 6 months later. So remember, he starts out like this, it goes like that. He looks better. He definitely looks better. I mean, his lips are almost even. Over here, the lips are certainly not even, but now you can see the lips are even. But the big thing was we increased the vertical dimension by putting that acrylic over the lower teeth to open the bite. Okay, that's what we did. Now, after maybe 6 months, he's here. Remember what he used to look like. I mean, 6 months later, you cannot do that with braces. You cannot do that with Invisalign. I don't care what Invisalign says to you or what anybody tells you, this is orthopedics. You have to open the vertical and look at the back where the lower molar has erupted. So that's opening the vertical. Now what we have to do is we have to bring up the bicuspids with elastics, with straight wire. Okay, that's our next step. Except that I think what happened with him, his mandible kept growing, and I had to go back in with a tandem for another 6 months, I believe. And I'll show you the design. Because remember, when you're 10 years old, you're going to grow to 17. You're going to grow to age 17, another 7 years. The mandible is going to grow more than the maxilla. So you better make sure you have some good appliances to advance the maxilla. Okay. So see, I mean that it's actually the second molar is touching. The second molar is touching, opening up the vertical. Now all we have to do is see what we're going to do next. But that's quite a difference between those two photos. An overjet of -4 and now an overjet of +1. That's a 5 millimeter change, but it wasn't 5 millimeters just due to the tandem. It was also due to the buildups. Okay. So because his crossbite was starting to come back, I said, we need to still move that maxilla a little more forward. And he's a good guy. He doesn't want surgery. So we did a fixed tandem. And Adam or Andrew, I'm sure you're using this most of the time now, aren't you?
Yeah, mostly. Well, unless we had a situation like you had where you had to open the bite almost an inch,
Yeah, right.
that's when we would do a removable with the acrylic, but mostly we do fixed. Yeah.
Okay. So, and this is bands on the first molar, bands on the first bicuspid, and hooks for the elastics, which we'll show you in a minute. So there it is. So if you have a choice, use this one because you can't take it out. It's fixed. So bands on the molars, bands on the first bicuspids, hooks on the cuspids. See the hook down there in the cuspids? You put that right in the bracket. Eh? Would you normally tie that to the appliance? Or do you put it right on the band?
No, yeah. So typically we connect it to the lingual wire on the appliance.
That's what I thought. Yeah. So because I think a few of them came off when we did this.
Mm-hmm.
But if you put them in the lingual wire, they don't come off. So again, we've been working with you for years, changing the design. And in fact, when I met with Dr. Klempner and he was speaking at my convention in Vegas, I showed him the fixed one, but he was using it mostly for young children. So he was using the removal one. And he was quite impressed that between us, we designed a fixed one, which we think works better. And he was very happy, but he thanked for him because he introduced this appliance like 20 years ago. So there's the upper. So there's the hooks in the upper. So there, you don't have to worry about it coming out now because that hook on the lower to the hook on the upper and that Class III elastic puts pressure on that all day. So why not put pressure on the mandible to not come forward and put the appliance in? Unfortunately, I guess I don't have pictures of the tandem, the fixed tandem, but I mean, same thing. We put the bow in the lower part and put the elastic on at night, and that's what happens. So then we put braces on them. And we kept the Hyrex in. Remember, you expand the Hyrex like 3 millimeters, you have to hold for 6 months, and then you can take it out, or it'll relapse. And these are just his final photos. Okay, so he's looking better. I like those lips a lot better than when we started. He was overclosed vertically. So if you really pay attention to that now, as dentists, we don't normally look at profiles. We don't normally look at the front of the mouth, the face, unless we're doing a denture or something. But you got to get used to looking at the face. Is it a long lower face, short lower face? And we do cephalometrics and we have measurements to tell exactly what's going on. And look at his face afterwards. He looks so much better, And there he is. And that looks fantastic. I mean, can you imagine if you saw that guy on the left? Let's say you're his grandfather, because I'm a grandfather now. Okay, let's say a grandfather saw him and then saw him next year on the right. Would he recognize him? I don't think he'd recognize him. I mean, he looks completely different. He looks fantastic, and I love doing this. And we can teach you how to do this. Between me and Andrew and 5-Star Lab, we can show you how to get results like this. This is not unusual. The tandem works all the time. You can't miss, especially the fixed one, Andrew, right? They can't take it out.
Right.
All they have to do is hook up their Class III elastics daytime and put in the face bow at night and hook up the elastics of the face bow, and they'll come forward every time. Okay, so it's not, could you, now I'm going to brag a little bit. Could you get a better result with surgery? I don't think you could. I don't think anybody could do surgery and make it any better. So why not do it non-surgically and not cut any nerves or not have any problems and fix him when he's like 10 years old instead of waiting until he's 17 and do surgery? If you do surgery on them at 17, they have to wear braces for 2 years after the surgery. Who wants to wear braces from 17 to 19 when you should be in university or college? Nobody. The parents will just eat up the fact that you can help these patients now and no surgery. I can tell you our practice is growing leaps and bounds. I now have a partner that just bought 45% of my practice because apparently I won't last forever, and have an associate. We have 7 ops, 2 consultation rooms, and we're cooking. But it's because we're doing something different. If you're a dentist, you should be doing something different. You should be doing something that the other dentists aren't doing in order to recession-proof your practice. There we did braces on them finally. Midlines are on, looking good. We put lingo bond retainers. Look at the Ceph. Look at the measurements. Look at the lips on the right, compare the lips on the left. What a difference. They're right on the line. That's where you want to be. Perfect. Okay. Anterior crossbite, normal overjet, no crossbite. Class 3 cuspid, Class 3 molar, Class 1 cuspid, Class 1 molar. I mean, that's fantastic. Now, the only problem was he's going to grow another 5 years or so. So I got to do something to prevent him from growing, having a relapse. But look at the face. I mean, would you recognize those 2 guys? I mean, they look completely different. Doesn't look like the same guy. The only thing is his hairdo is about the same. So profile good, full upper lip. So Andrew, we made him a couple of retainers. Now you can make these fixed or you can make them removable. I prefer fixed, but we made this guy a removable one, and we put a hook on the upper and a hook on the lower, and then he'd wear those elastics. But remember, if you don't have good retention, that lower is going to come out. That's why I really like, we could have put a lingual arch down there and put the hook on the buckle, and then it would never have come out. So that would have been, and you can also do a lingual arch in the upper. So today I do fixed upper, fixed lower with Class 3 elastics, which they wear for maybe 3 more years. And that keeps the mandible from growing forward and doesn't cause TMD problems because we've opened the vertical so much the condyles move down and forward, and he's in good shape. So again, another 3 years, just wear that. Okay. And he never came back. And believe me, when my patients, things don't work, they come back and they tell me. He never came back. So that's great. So that's a neat little trick to think about using a fixed or removable lingual arch. Afterwards, have Andrew design it for you and put those Class 3 elastics on for another 3 years to make sure you don't get the lower jaw coming more forward. And they just don't. So anyway, that's kind of it. But I love that face. I'm really happy I did that guy. I'm really happy the mother came to me after going to 3 orthodontists. 2 recommended surgery, which is not wrong. Surgery is not wrong treatment, but it's not preferred. I'd much rather do it when he's 10 or 11 than do surgery when he's 17. And the reverse face mask, as you say, wasn't wrong because you're going to be pulling the maxilla forward with that too. But he'd have to open the vertical for it to work, but hopefully he would have done that. So anyway, there's more than one way to treat a patient, but I just love the way 5-Star has all those appliances that can do things without surgery and improve the profiles and improve the face and fix the malocclusion. So again, I got a book on that, or there's an article in there, or the case in there on that. So that's basically it. I want you to know I'm 3 minutes late. I'm really disappointed because I practiced this presentation for 5 hours just to make sure I'd finish exactly on time. But so last night I did it for Toronto. I was 1 minute late and I'm 3 minutes late, but it's the best I could do. Well, thank you everybody for coming. If I can help you learn about orthodontics, I'd love to. And go online and look at my course, and there's a special on, and you'll definitely be working with 5-Star, and they'll be holding your hand all the way and making sure you don't make any mistakes. Because if you diagnose it right, you'll treat it right. But if you're wrong diagnosis, you got to start right to finish right. So the diagnose the key, and the design of the appliances is fantastic. And you can tell already from this guy, even though he doesn't have any gray hair, he's still wise.
Got a little bit going on in here.
Okay, well, that makes me think you're smarter than I thought you were. Okay, how old are you, Andrew? How old are you?
I'm 33.
Okay, and you've been doing this for what, at least 10 years, right?
Yeah, 10 years now. Yeah.
10 years now. So you've learned a lot. Thousands and thousands of cases. Yeah. Okay. Are there any questions?
Yeah, we do have a few questions. Let's see here. How do you decide whether to do buildups or occlusal coverage on an appliance?
Okay, that's a really good question. I prefer the buildups because the appliance is going to come out for sports. It's going to come out for eating. It's going to come out for cleaning, and they may forget to put it back in. So then you've got your deep bite again. So it's sort of temporary, but the buildups are permanent. They can't take them off. And you leave them on all the time. You don't ever take them off because you want all the other teeth to come up to that level. So the first thing is the first permanent molars are up. And then when the D comes out, the first primary molar, the first bicuspid comes up to that level. So it's just, I just prefer the buildups. And years ago, I used the occlusal pads, but now I use buildups as much as I can.
Yeah, one other thing to add to that is I mean, he showed it in that last case is sometimes if you have to open the bite a lot, you can't get a buildup to stay on. It'll just keep popping off if it's really big. And then if you put occlusal coverage on the appliance to get the lower first molars to come up into contact, you have to go in and relieve the acrylic 1 millimeter every month where it's touching that first molar so it can passively erupt. So a little bit extra work for you too if you're going to use the occlusal coverage versus the buildups, but there are some times where you just have to do it.
No, I think you're right. You could definitely use occlusal coverage, grind the plastic, and let the first molar passively erupt and open the bite. That's another way to do it, and it will work.
Okay, next question. Does recession go away when it's caused from traumatic occlusion?
Yes, and I should have shown that because that case completely cleared up when we corrected the anterior crossbite. It looks like perfect gingiva. So what I should do, I had that case, but I'm trying to cut it. I'm not trying to show too many cases, but that came right back to normal, which amazed me. But I told the mother we'd probably have to do a gingival graft, and we didn't have to. So it saved her, several $100s. So she was pretty happy. But that surprised me. I didn't think it would come back. I'm not a periodontist, but now I know what will happen. It goes back to normal if you get rid of the traumatic occlusion.
Okay, next one. Can you do an anterior sagittal with a tandem appliance?
Yes. Yes, and I think you're the one that taught me that. I think that you taught me that when you use a tandem, put a fixed anterior sagittal in the front with it, and it works faster. I think you're the first lab to do that.
Mm-hmm.
Because you've been famous for the barrel three-way sagittal that you guys are known for. So you put that on the tandem and you got two fantastic appliances which will work faster.
Yeah, we do that. We really do that a lot because, you have the anterior sagittal is proclining the teeth and pushing the premaxilla forward. The tandem's pulling the whole maxilla forward. So you just get kind of everything going at once. And yeah, we see really good results with doing an anterior sagittal and a tandem in conjunction.
Yeah. No, you're the first guy to do that.
Yeah,
the first lab I ever worked with that did that.
Yeah, Bobby invented the barrel three-way because his daughter wouldn't wear the removable one.
What a riot.
Yeah.
Good for the daughter.
She said, I'm not wearing that thing.
Right.
She said, well, I'll figure something out that you're going to wear then.
That's very good.
Okay, next question. What's the best age to start an anterior sagittal?
I prefer to use them. Well, first of all, you have to make sure the roots are completely formed. So I would, before I use it, I used it on a 5-year-old. No, I didn't use it on a 5-year-old. I waited till the permanent teeth erupted. So I would wait until, I like to wait till all 4 incisors erupt, the upper incisors. And I like to check the roots to make sure the roots are formed. But if you turn it slowly, remember, you're only moving the screw 1/4 millimeter each turn. It's so gradual. I've never seen it cause root resorption. But I think I would prefer, if I had a choice, maybe H7. Give those incisors a chance for the roots to form.
Okay, next question. Are there any contraindications for using the tandem?
Yes, a prognathic mandible. You need surgery. So if you have a normal maxilla, don't use a tandem. You only use a tandem if you got an underdeveloped retrognathic maxilla. So if you got a normal maxilla and a prognathic mandible, it's a surgical case. They have to surgically move the lower jaw back. So very important. Of course, you guys do cephalometrics. You have cephalometric tracings. And if the patient calls you, you can look at the model, you can look at the cephalometric x-ray, you look at the photos, and you can really help them a lot. And you give them a written report, right? Don't you give them, you give them a written report on how to treat the case. And that's really good. Just remember that you probably have on there that they make the decision. It's their, you're giving them some advice, but they have to make the final decision.
Right. Yeah, so that's one good thing too, is we'll do the cephalometric analysis, but then we also, if you want, can provide a write-up that breaks down all of the cephalometric measurements, what's important, what sticks out, what's normal, what's not, give appliance suggestions, do a model analysis, and then kind of walk you through how the treatment that you learn in Dr. Rondeau's courses. You know, here's your wire sequencing, here's the appliance that you need to use, here's how long you need to use it. So that's the service that we offer that I think is really, really important and valuable, especially as you're getting started treating cases.
It really is. You're the only lab that does that, that I know about.
And one thing I wanted to add to the tandem, and Brock talked a little bit about the reverse pull face mask. If you're not familiar with it, basically it's cup on the chin, cup on the forehead, and a bar that's attached right here that the elastics are attached to. So obviously the tandem is a lot easier for patients to wear versus a big old bulky face mask that goes across their whole face. So one thing, you don't see this hardly ever because usually you're not going to have joint issues in a class 3 patient, but the tandem appliance, all of the force, counteractive force is on the mandible. So if your patient is complaining about joint issues, you would want to discontinue that. And then maybe that's a situation where you would use a reverse pull face mask, but not very common for that to happen because generally a class 3 patient is not going to have your typical TMD, symptoms from a mandible being up and back.
Right. Especially remember when you increase the vertical. When you increase the vertical, the mandible rotates down and back, but it still comes out of the socket. And I've just never had one patient that I used the tandem on that they complained of temporomandibular joint dysfunction. So I think it's pretty safe for TMJ cases.
Next question. Are there any class 3 cases that you should avoid?
Well, I mentioned that one. Skeletal open bite, long lower face height. If they got an open bite, any kind of an open bite, skeletally or dentally, don't treat it. Because remember, when I open the vertical by putting the composite buildups on, the mandible rotates down and back and helps me correct the problem. But if you've got an open bite, you've got no help. And how are you going to correct that overjet? So you have to have a deep overbite. The key is the deep overbite, and the key is don't do it with an open bite. I mean, that's why you have orthodontists, but they will probably do surgery in those cases. But those cases maybe need surgery because we can't treat them well. So those cases get referred out.
Okay, next question. Why do you want to leave a class 3 with a deep overbite?
Oh, that's very important to restrict the growth of the mandible forward. So that's really important. So you don't leave a class 3 with a class 1 occlusion. You don't leave a class deep overbite with class 2. We use a ricinator or something to fix it. But with a class 3, definitely leave the deep overbite. Now, I suppose I could change that. If the patient was all through growing, then it might be okay to fix the deep overbite. But while the patient's actively growing, and girls grow to about 15 and boys grow to 17 or 18, then definitely leave the deep overbite to hold the mandible back. Good question.
All right, and that was actually the last question, but I did want to mention something, Brock, and have you talk about it a little bit. Don't you like to, when you're using a tandem, expand a little bit before?
Yes, yes, and I didn't mention that, so I'm glad you brought that up. What you need to do is expand the upper arch first, about 3 millimeters, before you activate the elastics in the tandem. So that's very good. You reminded me of that. So for sure, everybody, don't put the tandem in and start off with the class 3 elastics right away. You have to expand the maxilla a little bit, and the research is out of McNamara. Took his course 30 years ago, and he said you have to loosen up the sutures a little bit with the Hyrex, open it up about 3 millimeters. And then when you pull forward, because he was talking about reverse face mask in those days, there was no tandem appliance, it works a lot better. So that's a really good point. I'm glad you mentioned that.
All right, and that's looks like that wraps up all of the questions that we have. So Brock, do you want to say something and then I'll close us out?
I just thank everybody for attending, and this is, of course, all videotaped. So you're going to be able to take your time and go through the thing, and then you can ask Andrew questions that come up later, or send them to lee@rondeauseminars.com, and we'll be happy to help you, because we're here to teach and to help you grow your practice and help more patients. But I mean, if you start doing this, you're going to love your practice. All I can tell you, because what I like about functional appliances and doing our techniques, we get appreciated and patients thank us. I say as a joke, I've never been thanked for a filling before. So who's going to thank you for giving them a needle, drilling a hole in their tooth, filling it, and then giving them a bill? The drill, fill, and bill. You need the drill, fill, and bill to make money and run your practice, but you need this one too to add to your income and also psychologically make you feel better about being a dentist, because you're going to help patients that maybe someone else in the area is not even going to be able to help. So that's my last word, and just happy to be working with you. Again, looking forward to the courses this year, and you're a great lab, and I'm glad to be acquainted with you.
Yeah, thank you. Well, again, Brock, thank you so much for doing this evening. As always, great to see you, great to talk with you, and great to hear you speak. And then one thing I will say for everybody is Brock talked about the manuals that you get with the course, and I can't stress this. I mean, those things are worth the price of admission in themselves. They're so thorough and so helpful to you as a reference when you start treating cases after the course and even during the course. I mean, they're the best manuals that you'll get at any course out there. They're really phenomenal. And so if you're thinking about the courses, you need to do it, because those manuals, you'll get them, and they're worth their weight in gold for sure. So thank you again, everybody, for joining us tonight. Hope to see you at the courses coming up in the fall, and hope you enjoyed this lecture tonight, and enjoy the rest of your evening.
Thanks, Andrew. Thanks, everybody.
Bye, everyone. Thanks, Brock.
Bye-bye. Good night, everybody.